So I think really in order to understand, obtaining alignment of the femur, I think it's super important that we also understand what is normal alignment for the femur. And so the objectives I have really is to understand what is normal femoral alignment when it comes to fixing shaft as well as distal femurs. And then we will cover some techniques to help accomplish this. And Dr. Leonard will further dive into techniques to kind of bring everything home. So when we look at a femoral alignment, there are different things that we look at, right? We always look at length, alignment, rotation, and there's also offset. And so with an alignment, you have two different things, and we all know this, right? You have your mechanical axis and your anatomic axis. You do have a femoral offset from each other, from the midpoint of the pelvis, which is both different in the mechanical and anatomic axes, as well as your length. And these have to match. And then, though we're not really going to delve into the proximal aspect of the femur, there is the rotational components, right? Which we call anaversion. And this is just basically what the neck is in relation to the shaft. And it's important really for all femur fractures. And I think it's part of the checklist that we go through when we look at femur fractures. And are we getting this right? John put up a slide earlier that talked about these values. And these are super important when it comes mainly to the more distal third of the femur, but these are values that you really need to know, because when you fix these fractures, you sort of want to gauge this type of relationship to make sure you're getting it right. And so there are different techniques, right, in order to get this. We always ask, okay, so what are some ways of rotation? You can look at the lesser trochanteric profile, compare it to the other side, the femoral neck angle, and this is just basically looking at if you're going to take an AP, and that way we're taking a lateral of the distal femur, coming up and looking at the neck, taking a lateral and just staying lateral and looking at the anaversion on that. Your coronal alignment, right? You can do it intraoperatively. Look at the bovie cord, take it right at the top of the center of the femoral head, all the way down to the ankle, and kind of see where you are at the knee compared to the other side preoperatively. Or you do these angles, right? And you can do it with flat plates, or you can do it intraoperatively. All these different things. And you look at your length, radiographic rulers come into play. So again, all these different things really have to be thought out and planned before you take this surgery on. So this is a case example where I employed some of these different ways to do this. And fortunately, this was the case I just recently did. So I'm glad I was able to have this. So this is a 40-year-old male with an open distal femur fracture, segmental bone loss, comminuted intra-articular fracture. So again, one of the biggest things that we have to look at is, okay, so, we know that there's significant bone loss. And so length is going to be an issue. And that's already something that we should know ahead of time going in. And then we have to look at the coronal alignment, right? We have to look at the rotational alignment. So we're going to play all these different things in order to get this right. Full disclosure, this patient did have a traumatic below knee amputation, but we can pretend that this is a normal limb. And so this is kind of what we're dealing with. So not only do we have to get the joint right, and we're not going to dive into how we fix distal femur fractures, but you have to get the joint right, and you have to get the alignment right. So this is a pretty involved surgery and lots to go about. And what I do, which I think is helpful, is on the actual C-arm, I actually will take a paper and I will write down a checklist, and I will actually tape it to the C-arm because I'm looking at it all the time. And as I'm doing the surgery, I'm making sure that I'm checking off rotation. Okay, I check that, alignment, coronal, all that stuff, just to make sure that I'm not missing anything, because it's really easy to miss something because you're dealing with this injury and trying to put it back together. So how do I do this? So one of the things I do first is I look at the opposite side, right? So I take a radiographic ruler you can get in any nailing set, and I just look at the regular limb. And so I compare it. You can compare it to the notch, you compare it to the physis. And the other thing I do is I look at the normal side, and I'll look at angles as well. Okay, so we have an idea. So this is kind of intraoperatively where I am, and I'm looking at the alignment and making sure that I'm relatively close close in getting what I want. And I can see that I might be a touch short, and I'll definitely accept that. But for the most part, it is fairly close to where I wanted to be. And again, his soft tissues were really bad, and I felt like if I really got him full length, I was already getting a hard time closing it. So I did err on the side of the small shortening, but really it's way less than a centimeter. So that's one thing you can definitely do to look. And the second thing is your alignment, right? So we talked about those angles. And so one of the things is I do is I measure in preoperatively. What Chuck mentioned about those flat panels, we actually have a flat panel at our institution, and it is really great because it does not have parallax, but also because the way it's made, you can actually get not truly a long, like a full length cassette, but you can actually get a pretty good image with the knee centered and have a lot of the shaft to work with to get these angles. And so you can send them to PACS right away and start looking at the contralateral side early. And then intraoperatively, you can actually look at it too to make sure that you're fairly close to where you want it to be. And here he was, again, fairly close. And so again, and one thing I also did want to mention is also when you look at coronal alignment, when you look at your plumb line down the femoral shaft, you have to also pretend that, if you're going to retrograde nail this, this line should be right where your start point is going to be. And your start point really is going to be right at your medial tibial eminence where it's on the femur. And so that's another great way to help make sure your coronal alignment when it comes to the shaft in relation to the distal femur is appropriate. A lot of times I see the shaft lateralize so much with these segmental bone losses, but really the correct alignment is this plumb line dropped all the way down. Here I might be a touch lateralized, but plumb line dropped all the way down to show that the overall shaft to the distal block is in the appropriate position. And then again, my measurement had not changed, so I know my coronal alignment was set up. And I forgot to take images of the rotational profile, but suffice it to say, it was right on. So those are different ways that you can use these techniques to help with fixating these really tough distal femur fractures. And now I'll just let Dr. Learned take over and dive into, I guess, more of the shaft and other great techniques. So I'm going to stop sharing.
Yeah, it's I think it's, again, this is a topic that is worthy of longer discussions, but suffice it to say that we have challenges in the shafts, and especially get towards end segments and then don't have any continuity of care. We saw a lot of examples in the tibia where clamps were used for direct reduction, but you were essentially using techniques to fix a free floating distal segment to a shaft that was a couple of zip codes away, due to the bone loss. So these can definitely be challenging injuries. So James, I'll turn it over to you.